Well, good evening once again, everyone. Can I just get a quick yes or no in the chat, loud and clear? Thank you very much. Somebody was ready with the button. So welcome along. Thanks for coming this evening, guys. As predicted, a slightly smaller crowd for this one. This is Oxygen and Entonox Guidelines. We're going to be talking about this evening. Fairly short subjects, but it's one of those subjects that you do need to know if you're going through for FREC 4. And of course, those of you that have done FREC 4, you might find it useful just to recap on when we should and shouldn't be using the medical gases. So welcome along. Any of those that are new to this, then very good evening. Thanks for giving us your time, and we hope that tonight is useful for you. STC Training Solutions is a pre-hospital care training provider based in Aylesbury. We teach predominantly the FREC 3 and FREC 4 courses at the moment, plus all the add-ons. And we're developing our FREC 5 program at the moment, hoping to launch that in spring 22. We put this set of webinars together for those of you that are working through the FREC pathway with a view to this being some really kind of focused CPD for you. Predominantly those of you going between FREC 3 and FREC 4, because there is a fair jump in all your required knowledge. And of course, as I've said, some refresher for those of you that have been through it already and looking to keep up to date. So Oxygen and Entonox is one of those subjects that you just need to know for FREC 4. It is covered, Oxygen anyway is covered as standard at FREC 3, and we offer the Entonox bolt-on to FREC 3. So lots of you that have done it through us anyway will have already covered both. But a lot of people going into FREC 4 will never have used Entonox. So this is what tonight's all about. My name's Dennis, I'm a paramedic practitioner by trade, 8-9 years experience frontline ambulance service, and now a couple of years in primary care. So if there's any questions as we go along, please feel free to ask. We'd like tonight to be as interactive as possible. So we've got Charlotte in the chat this evening. So if you've got any questions, we go along, throw them in there. And of course, we'll have a Q&A session at the end. So we've started a bit of a trend now, haven't we, with the quiz at the end. So those of you just joining us, welcome along. There is a quiz at the end, and the prize is 10% off any course of your choosing, and we will honour that against FREC 5 as and when that gets up and running. So come on in, those of you that are just joining. We'll just give you a minute. So yes, absolutely. So that's what tonight's all about. As I say, we are a FREC training provider. So we do, of course, have some up and coming courses. If anyone's interested in joining us face to face, we'd love to see you. Spaces are running out now for courses before Christmas. So do get in there if you need one. Only a couple of spaces on the 20th November weekend FREC 3 course. We've got the option of weekends or Monday to Friday for both courses. The weekend FREC 3 is filling up. There is one space left on, no, sorry, I've updated it already. So the Monday to Friday one starting on the 6th of December is of course going to be the last FREC 3 before Christmas. So there is still space on that one. FREC 4 starting on the 8th of January is the next weekend course. There is only a couple of spaces left now. That's been selling out quite quickly. As the Monday to Friday FREC 4, there is only one space left on the 22nd of November if anyone wants to join us for that. Next ILS, 12th of December. That's always a good day, so come along for that. It's only £95. And Safe Administration and Meds, which the next one, we put an extra one on because we were filling them up so quick. So we've got 18th and 19th of December for the next Safe Administration Lifesaving Meds course. Really good add-on. And we will be doing a webinar in a couple of weeks, well, a few weeks' time on the SARM medications, if anyone's interested in that. Welcome from Lanzarote. So, Rowie, we'll see you in a couple of weeks' time. I hope you get back okay for that. So, but I hope you're having a wonderful time. And good evening to all our usual regulars. Thanks for joining us. So we'll get going. Oops, he says we'll get going. There we go. So what have we done so far? This series has been quite a long one, actually. It's nearly nearing the end. We've done CPD requirements, as we've mentioned. We're going to update that one before the end. The anatomy and physiology sessions were split over two. We did lots of pathophysiology, lots of diseases. We've talked about maternity care. We've talked about patient assessment, paediatric assessment specifically. We've talked about sepsis, and now we're on to oxygen and Entonox guidelines tonight. As I say, a relatively short one in comparison to the others. We're going to start with ECG Basics next week's two-part series, two-part kind of mini-series. So ECG Basics Part 1 next week, Part 2 the week after. Then we'll be going on to the theory of intermediate life support, and by popular demand, we're going to do the SARM medications refresher. There has been some changes any of you that have done your SARM in the last year or so, there have been quite a few changes, particularly around anaphylaxis. So we'll go into that. So tonight we're just going to look at some medication terminology for those of you that haven't come into contact with medications before. There's some words you'll need to know. We'll be talking about safety of gases. Obviously, they can be dangerous if mishandled. Oxygen guidelines, Entonox guidelines, and of course delivery equipment. There'll be the quiz and the Q&A session at the end. As always, be interactive. Get your smartphones out because we'll be using Mentimeter again very shortly. And if you want to take part in the quiz at the end to win 10% off, then of course you will need to do that. As always, if you think of something after the event, then feel free to drop us a tweet, an email, text, anything like that. We can get in touch with you. Recommended reading, as always, is Ambulance Care Essentials or Ambulance Care Practice. Ambulance Care Essentials is the core material for FREC 3, Ambulance Care Practice for FREC 4. JL Calc is the Bible for anything to do with pre-hospital care. The 2019 guidelines are out of date, so I don't advise buying them at the moment. Get the app if you've got money to burn. Otherwise, wait for the next printed version to come out if you do prefer a textbook. Also, I'll say on the recommended reading, if you go to the BOC website, there's some useful downloads there as well, free of charge, on gases safety and use of oxygen and medical entonox. There's some drug terminology then to get us started. So this is just for those of you that have never been involved in medications or drug administration before. There's some words that you just need to know of, and presentation is the first one. Presentation is you'll see that written all over the place, particularly in JL Calc when you start using the JL Calc guidance to administer medication. The presentation is how the drug is packaged. So obviously the gases we're going to be talking about tonight, their presentation is a cylinder. Obviously those cylinders come in different shapes and sizes, different manufacturers, but predominantly they're all in compressed gas cylinders, and they all have relatively similar ways of turning them on and off. The dose, of course, is how much of the active ingredient is actually given. Now, sometimes, particularly with injectable medication, even when you get on to administering that, is given as a dose within a volume. So, for example, adrenaline, 500 micrograms within half a mil of solution, so whatever it's dissolved in. But normally, when we're talking about handover and things like that, the doctors that you're handing over to in hospital are only really interested in the active ingredient that's been given. So we don't want to know, for example, if you've got somebody with anaphylaxis, you've been giving them, half a milligram of adrenaline every 5 minutes for the last 40. They just want to know the total. They've been given a total of 4 milligrams of IM adrenaline. We don't need to break that down into 4 milligrams of IM adrenaline in 4 mil. That's a given. But so you'll often hear different ways of expressing dosage, but the most important part is the active ingredient. And do make sure you've got the units correct. If you come and do the SARM course, there is an exam on converting between units of measurement. The frequency is how often you can give the medication. Sometimes it is just a single stat dose, but if it does say every 3 to 5 minutes, then absolutely you can repeat the dose. And of course the interval, the frequency is how often. The interval is the minimum time between those doses. So for example, adrenaline and anaphylaxis can be given every 3 to 5 minutes. Indications, I put is a big one, that's why it's in green. Indications you'll hear all the time is situations in which you can give the drug. So for some drugs there is only one indication, for some drugs there are loads of indications. So the drugs we're going to talk about tonight, oxygen and Entonox, have limited indications, but you do need to know them. Contraindications are reasons that you cannot give it. So there's situations in which you must not give the medication. You're not allowed to deviate from contraindications. Cautions, however, are situations in which you probably could give the medical, or you could give the medication, but you probably want to keep a close eye on how the patient does. There are some interesting ones around Entonox, which we'll talk about later. So the cautions don't mean you can't give it; they just mean you need to be cautious, obviously. And maybe monitor the patient a bit more closely than you would normally. Side effects are, reactions that are not intended, and then you'll hear this term adverse reactions, so negative side effects that cause harm. So adverse reactions or allergies is the correct terminology, is adverse reaction. A side effect is just something that happens that wasn't intended, but it might not actually cause harm. It might actually be a negative. A side effect of morphine is euphoria. Patients aren't going to complain about that, but it is a side effect still. Adverse reaction would be obviously severe vomiting or those types of things. So good. So now we've got the terminology out of the way. Let's look at the anatomy of a gas bottle. For those of you that haven't seen them, these are the two main manufacturers you'll see out there: BOC on the left and middle, and SOS, Specialty Oxygen Services, on the right. SOS are becoming very, very popular, particularly within the private world, because they are much more reasonably priced. BOC are ridiculously expensive unless you're a trust. So you'll see more and more of the SOS bottles out and about, but BOC, if you work in the NHS, it's BOC everywhere. So I've put on the left-hand side of the picture there, you can see the kind of standard CD size cylinder, which is the small 460 litre bottle that you normally carry around with you. Okay, just bear in mind they don't last that long on 100% oxygen, so do know where your spares are. The one in the middle is the larger ZX ones that are fitted to the ambulances. They've got much longer run times. I think they've got something like 1,600 litres in each. Can't remember off the top of my head, but they run for an awful lot longer. You've got the SOS bottles, which do exactly the same. They have the smaller everyday carry ones, and they have the bigger vehicle-based cylinders that you may also see on trolleys around A&E. Sometimes they have those massive Entonox bottles in trolleys, because obviously the small ones don't tend to last that long. This is what an Entonox cylinder looks like from BOC. You can see that the main difference is that it's got some blue striping on it, and it says Entonox. That's generally the good giveaway. But of course, the blue stripe, even in the SOS bottle, you can see there in the far right of the picture, has a blue stripe on it. That is to signify Entonox. Now, I really shouldn't use the term Entonox. The official term is nitrous oxide. Entonox, as you'll see shortly, is a brand name of BOC, actually, and because fewer and fewer of the private companies in particular are using BOC, we really shouldn't be calling it Entonox as standard. It should be called nitrous oxide. The brand name for SOS, if you're interested, is Nitronox. So they're all relatively similar, but Entonox is still the most used kind of term, if you like. It's a bit like Hoover, isn't it? So you just kind of use the word, but actually Entonox is only the brand name of BOC. So a little bit of gases safety just to talk about. It's all fairly common sense stuff, but we don't smoke or when we're using or handling cylinders, and that also goes for your patients. So I'm sure you can picture the scene. Some of you go in and there's got cotton in the corner smoking away and coughing her lungs up on a nebulizer. Yeah, we certainly wouldn't want to be giving oxygen to that patient while they're smoking. So obviously, I would hope that not many of you are going to be smoking whilst using the cylinders, but the patients may well have other ideas. Don't store cylinders over 50. I mean, let's be honest, it's going to be a while yet before, and I hope I'm not around to see it before we get 50-degree summers in the UK. But the inside of the ambulance can get fairly close to 50 degrees because the air conditioning never works, of course. Oil or grease, so anything hydrocarbons can spontaneously combust around oxygen, so we don't use any oil or grease or anything like that around them. So got a really sticky kind of, back in the olden days when we had to use the valves, the spanners to open the gas valves, and they got really stiff. People would be tempted, I'm sure, to put WD-40 and things like that on them, but don't. Could go boom. Store in a well-ventilated place. I mean, it's not that it's going to do you any harm, but it's just good practice. Obviously, with other gases that may do you harm, of course, they've got to be well-ventilated, but oxygen isn't going to hurt you. Entonox is going to make you feel a bit funny until you get away from it, but ultimately, you're not going to cause damage to yourself, but still good practice. Don't use in explosive environments. As you'll see, it's the contraindication for oxygen. Only use the equipment designed for the task. No trying to ram the ventilator into the Entonox bottle. Yes, the patient will like it, but it's not supposed to work that way. One thing is supposed to plug into one particular bottle. So ventilators go into oxygen bottles. Only Entonox demand valves should go into Entonox bottles. So don't try and wedge anything in that shouldn't be there. Close all the valves when the cylinder's not in use, and that is also a really important point to note about connecting and disconnecting the equipment. We will have a look at the end, just at the Entonox delivery equipment, and how you connect that in. And sometimes when you come to disconnect it, it can come out with quite a bit of force. So what we do is we turn the bottle off and then purge the system to get rid of any gas in the pipes before we disconnect any of these connections. I have seen someone have their tooth knocked out, so their front tooth knocked out by a flying Entonox connector, Schrader valve connector. So it can happen. So always turn your bottles off. And of course, there was that tragic incident a couple of years back, I think in East Midlands or East of England, one of those, where a patient died because an oxygen bottle exploded. And that was thought to be down to the bottle not being turned off between connecting and disconnecting. equipment. So do just close the valves properly when you're not using them. Leave them upright. It's not because they're going to fall over; they'll explode. They're really strong, but it's just good practice again just to have them laid down when they're being stored. The large cylinders that you're going to be putting in and out of the oxygen cabinets of the ambulances as well. Just bear in mind they are heavy. Officially, they are 2-man lifts in the trusts, but I know we all do it ourselves, but they are heavy. Just watch that out. So. Okay, we'll flick over to Mentimeter then. Let's get interactive. So give me 3 indications for oxygen. So if you haven't used Mentimeter before, go to menti.com, put in the code 76818049. The code is written at the top of the screen. And give me 3 indications for oxygen, please. So indications being a reason that you can give it. Give me 3 indications. There are 5 in total. So menti.com 76818049 is the code. It's written at the top of the screen. I'm assuming people are typing away in the background. Should have asked an easier question that didn't require a 500-word answer, shouldn't I really? Why is it not showing? Okay. What's going on here then? Fine. So has there we go. Mentimeter is just having a moment. All right. Oopsie daisy, don't answer the other question just yet. 3 indications for oxygen, fab. Okay, if you can all see that again. There we go, it's woken up now. Good, okay, drowning. Can you see it now, Rui? Low saturations, good. It's a little bit more wordy than that, but absolutely. Sepsis, I like that, good. Hypoxia, smoke inhalation, drowning, cardiac arrest. Hypoxia, good. Heart attack. So think about heart attack. So heart attack isn't actually an indication for oxygen. There is some evidence that if you give people oxygen, it does. Codes at the top there, Cindy, so 76818049. 76818049. So if you give people oxygen, we get a little bit of vasoconstriction, i.e. the smaller blood vessels constrict very slightly. In situations like heart attack and stroke, actually, that's not a good thing to happen because we're restricting the flow of blood already. Labour pain, so not for oxygen, but good. I'm liking cardiac arrest, smoke inhalation, hypoxia, trauma, sepsis, drowning, low sats. Good, okay, let's flick back. So the indications for oxygen are taken from JL-Calc. JL-Calc is our Bible when it comes to anything to do with drugs or pre-hospital care in general. So for adults, there's 4 indications. I'll pop them up because I'm going to say to you that the 2nd and the 4th indications that you can see there are basically the same thing. So there's somebody in JL-Calc that really likes making things wordy when they don't need to be. And unfortunately, that person has a job of writing some of our guidance. So there is basically those 2 paragraphs mean the same thing. All right. So one says serious illness requiring moderate levels of supplemental oxygen if the patient is hypoxemic, or conditions in which oxygen is only required if the patient is hypoxemic. What's the common denominator there? It's if the patient is hypoxemic. Hypoxemic is a posh word for low blood oxygen levels. Okay. So if their saturations are low, the person in JL-Calc that writes this stuff probably should just write indications for oxygen, their oxygen levels are low, because actually it doesn't matter what's going on underneath, whether it's a serious illness or a condition in which oxygen is only required, blah, blah, blah. If they have low saturations, they need oxygen. So take paragraphs 2 and 4 to mean the same thing. Low saturations, we'll come on to what that means very shortly. Critical illness requiring high levels of supplemental oxygen. That's the first paragraph there. That one is the easiest one because that just refers you to something called the red box, okay? If you have a copy of JLCalc 2019 in front of you, it's page 604 of the guidance, and that gives you a list of conditions where the patients are always going to be given 100% oxygen regardless of what's wrong with them. Okay, so we'll come on to those. And then you've got COPD. COPD or other conditions requiring controlled oxygen therapy, but generally that's only if their oxygen levels are below a set level. Now we will come on to it. We did talk about it in the respiratory pathophysiology session around the differences between healthy adults and COPD patients. But there is a lower threshold, if you like, for giving patients, a lower point at which we start giving oxygen to patients with COPD. And that's because of something called hypoxic drive. We don't want to give them oxygen too early. If you haven't heard of any of this, if this is all alien to you, then do go back and look at our video on respiratory pathophysiology. So COPD patients, they require controlled oxygen therapy. What that basically means is you start low and work up. So rather than blasting a patient, so for example, a critical illness requiring high levels of supplemental oxygen, you blast them with 100%. With a COPD patient, you want to just kind of give them a little bit more, and until you get them to where you want them to be. And then, as I say, the other two paragraphs are just any patient with stats less than 94%, which would be hypoxemia, wouldn't it? For children, really nice and easy. Just hang a moment. There we go. Significant illness and or injury. It's nice and subjective. It's nice and open. If you've got a child that's injured or unwell, give them oxygen. Okay. What we were talking about the other day on one of our courses is, generally speaking, the only children that need oxygen are the children that are going to let you put an oxygen mask on their face, because generally children won't let you put a mask on their face. So if they're really unwell and they're kind of lower levels of response and things like that, they will tolerate having the mask. They generally need it. But no, any significantly ill or injured child gets 100% oxygen. And it's nice and easy with kids. There's no titrating or anything like that. It's just if they're unwell or they're injured, give them oxygen, and it's 100%. We generally don't carry Venturi masks for kids anyway. So contraindications and cautions then. So there is one contraindication, and that's explosive environments. That makes sense, right? Oxygen in an explosive environment is only going to make the situation worse. At the same time, I consider my contraindication to be explosive environments. I have several contraindications, but one of mine is explosive environments too. I tend not to put myself in them. So for me to be standing there with a bottle of oxygen, something has gone catastrophically wrong for me that day. So if you ever see me in that situation, just feel free to drag me out. Cautions, on the other hand, are ones that you probably are going to come across from time to time. So oxygen does increase the fire hazard on scene. Again, you just have to bear in mind no naked flames, no smoking, any of that type of stuff. And then the defibrillator pad debate, isn't there? So what happens with oxygen when you're defibrillating a patient? We all know that, in an open circuit, we shouldn't be flooding oxygen all over the patient's chest through the BVM whilst they're being defibrillated, because that spark could cause some ignition to occur. So we generally hide the BVM behind our back, don't we? So that's your contraindication and your two cautions for oxygen. So let's go back to menti.com. It's the same code, 76818049, and give me 3 examples of when 100% oxygen is always used. Okay. Try and do it without looking at page 604 that I didn't catch diverted you to as Siri wakes up. So give 3 examples of when 100% oxygen is always required. Children, no, not always for kids. If the child is well, it doesn't need 100% oxygen, but they are, you're right, if they are injured or significantly injured or ill. Pulmonary hemorrhage, decompression illness, good, shock, I like that, major trauma, cardiac arrest. Trauma, so that's with major trauma, and each trust does define that somewhat by themselves. Cardiac arrest, most people going for. Decompression illness, absolutely, because of the nitrous oxide expansion, or nitrogen expansion, sorry, not nitrous oxide. Shock, critical injury, yeah, so major trauma, absolutely, critical illness. Good. Okay, people are on the right lines. Let's have a look. What did JLCalc say if you haven't got a copy of JLCalc in front of you? So cardiac arrest or resuscitation, carbon monoxide poisoning, major trauma, anaphylaxis, decompression sickness, major pulmonary hemorrhage, sepsis, shock, and drowning. Okay, there are 2 odd ones out, which we'll come back to. Cardiac arrest and resuscitation, clearly that is, you are indicated for 100% oxygen. Now, There is a lot of evidence coming through about post-resuscitative care around whether we should be over-oxygenating our patients or not, and actually, so there may be some changes around the oxygen guidelines in patients that have ROSC. And actually, already in the trust I work for, we're already advocating SATs measuring as soon as you can after ROSC, and actually paying more attention to end-tidal CO2 than we are paying oxygen. And actually titrating down the oxygen post-ROSC is already advocated. Carbon monoxide poisoning, because carbon monoxide has a greater affinity for the hemoglobin in the red blood cells than oxygen does, or should I say the other way around, the hemoglobin has a greater affinity to carbon monoxide. So we need to kind of drown it out with oxygen in order to give the red blood cells a chance of forming oxyhemoglobin. We have major trauma. Again, each trust does define that, a little bit themselves, but it's big things like, open femur fractures, penetrating chest trauma, significant head injuries, those types of things. But each trust will have its own guidance on that. Anaphylaxis, clearly 100% oxygen. That's part of your anaphylaxis 3-point plan, isn't it? Decompression sickness, again, we talked about the nitrogen bubbles. Major pulmonary hemorrhage, if the lungs are full of blood, then give them a chance to, what little bits are working, give them 100% oxygen to soak up. Sepsis, because it's a form of shock as in hypovolemic, cardiogenic, all the other types of stuff. So low blood pressure, high heart rate, high respiratory rate. If we think it's through blood loss or distributed shock, then go for it. And drowning again, just to kind of reduce the chances of secondary drowning by over-oxygenating those patients. So the two odd ones out are the active convulsions and the hypothermic patients. And that is just because you administer 100% oxygen until you can establish accurate saturations. Now, the reason they're in this box is just because during a fitting, it's very unlikely you're going to get a good SATs trace, or very unlikely the SATs probe is going to stay on with some patients. Hypothermia, again, because of poor peripheral perfusion, you're unlikely to get accurate saturation. So with truly hypothermic patients, we would give them 100% oxygen too. So back to Menti. What's the next one I have in store for you? What are the target oxygen saturations for a patient with COPD then? 76818049 at menti.com. Thanks, Matt. You're not going to drag me out. I like the logic. As I say, something's gone very wrong if I'm anywhere near an explosive environment. I'll be in Costa, waiting for Heart. Heart can deal with that. So menti.com, let's just let a few of you vote there. Brilliant. Let's see where most people are going. 88 to 92. Some of you going 84 to 92. The correct answer is, of course, 88 to 92. Well done, Marie. Perfect. Yeah, 88 to 92. Very good, folks. That's the target oxygen saturations. What do I mean by that? If you had a patient with COPD and their saturations were below 88, you would give them oxygen, but you would only give them enough oxygen until they got into that range, so 88 to 92. If they get above 92, you're giving them too much, turn it down. If you don't quite get to 88, you're not giving them enough. That's what we mean by target saturations. Of course, normal saturations for someone with COPD are just 88 to 100, okay? So 94 to 100 is normal saturations for a healthy adult. 94 to 98 are the target saturations for a healthy adult. And 84 to 92 was just red herring. So 88 to 92 is the correct answer. Most of you getting that right, well done. Okay, let me just make sure, am I sharing the right screen? Has it come up? There we go. So CPD guidance, as we just said, oops. Computer says no. 88 to 92, recommended initial therapy is 2 to 4 litres through a nasal cannula or a 28% Venturi mask is what JL Calc say. Increases necessary to achieve those target saturations. So patients with SATs below 88% have got COPD. Don't rush in there with 100% oxygen. Start them low, work them up. Ultimately, you may end up on 100% oxygen. That's not to say you don't ever give 100% oxygen to someone with COPD. That wouldn't be your first port of call. In critical illness, though, GL Calc red box guidance still applies. So if you've got a patient with COPD that's been hit by a bus and has major trauma, you still give them 100% oxygen. Or if they've got sepsis, still give them 100% oxygen if they've drowned, etc. All right. If it's in the red box, it doesn't matter whether they have COPD or not. The only caveat to that is if it reduces their level of consciousness, then you can stop the 100% oxygen. Okay, so we talked about hypoxic drive, as I say, in the respiratory session, so do go back and have a look at that. For everyone else then, 94 to 98 is the target. Just some guidance here. If their initial SATs are below 85, this is healthy adults. If SATs are initially below 85, you would go straight in with 100% oxygen. If their SATs are between 85 and 93%, then you've got a choice. You can either use a nasal cannula. You can put up to 6 litres through a nasal cannula. I'll show you a photo of one at the end if you haven't seen one. That's the only one you have to decide how many litres a minute to put through it. So every one increases the inspired oxygen concentration by 4%, which is quite an interesting fact. So 1 litre will give you approximately 24%, and 6 litres will give you approximately 44%. Venturi mask, again, there are different types out there. They all have different flow rates on them. The trusts will normally only have the choice of 1, but you can buy 28, 32, 40, 60. There's loads and loads of different concentration available of the Venturi mask, but too much choice is never a good thing. So the trusts, as I say, normally only have the choice of 1, whether it be 30 something, 40 something, and normally just called the medium mask. So, good. Let's head back to Menti then. I reckon this might be a question on Entonox. Let's see. There you go. When would you consider using Entonox? You can give up to 3 answers. Anyone that's done this before will know there is only 2 indications for Entonox, but give me 3 up to 3 things that would make you think of giving Entonox. Fracture, good. So what is it about the fracture that we're treating? Have I frozen, or is everybody else? No, there we go. Moderate severe pain, labour pain. Haha, yep, good. Good, yeah, Rory, absolutely correct in the chat. We're giving it for pain relief. So fracture is right. Self-administering, good. Yes, it is. Labour pain, childbirth, burns, good. Yeah, absolutely. Trauma pain relief, good. Always think about heart attacks and things like that as well. Chest pain, it can be very, very good for myocardial chest pain. Good. Dressing change, good. Yeah. Yep, chest pain. Lovely. Yeah, it's one of our ACS bundle actually in the NHS. So when you've got somebody with acute coronary syndrome, there's a bundle of things you should offer them. And Entonox is one of them. Good. Lovely. Yeah, people on the right lines. That's fantastic. So as I've said, technically, according to JLCalc, which is who we follow, there are only 2 indications for Entonox, and they are moderate to severe pain and labour pains. Now, I would challenge you to find somebody that's been through labour that wouldn't class that as a moderate to severe pain. I've not met anyone, and I've seen enough labours to know that that probably is the same thing. Again, that person in JLCalc came out of their box again, didn't they, just to throw something in there. So actually, let's just say labour pains. Good. So moderate to severe pain, and that absolutely includes labour pain. Entonox, as I say, is a brand name of BOC. It is nitrous oxide is the official title. It's inhaled analgesic, pain relief and gas. Rapid onset, but it wears off within a few minutes. I think most people would describe it as being instantly happily drunk without the hangover, and it wears off very, very quickly. A lot of people don't like it though. A lot of people, it makes them feel quite sick or kind of disconnected from reality, and not in a very good way. But it's not actually understood how it works. It's just one of those things. Yeah, it doesn't seem to do any harm, so crack on. But actually, nobody really understands why it works. It's something to do with the nitrous oxide and how it affects the brain. So. Contraindications and cautions. Okay, there are 5 contraindications for Entonox, and there is 1 caution that's quite wordy. Okay, so there are 5 reasons why you must not give Entonox. Severe head injuries with impaired consciousness, so anyone with a reduced GCS after a head injury. Decompression sickness, so if they've been diving within the last 24 hours, they are at risk of decompression sickness too, so that's included. Violently disturbed psychiatric patients, so don't give it to your crewmates. Intraocular injection of gas within the last 8 weeks. 8 over 52 means 8 weeks in shorthand. Intraocular injections of gas are normally given to patients with eye degenerative diseases such as glaucoma and things along those lines. So the patient will absolutely know that they've had that done, and but they may not know that they can't have Entonox. Okay. and abdominal pain where intestinal obstruction is suspected. What makes us think intestinal obstruction? Lack of bowel sounds, no bowel motions for a good number of days, and severe abdominal pain, that type of thing. Of course, caution. The only caution really is any patient with chest or abdominal injuries. So basically anyone that's at risk of pneumothorax, pneumomediastinum, or pneumoperitoneum. So pneumothorax is air within the pleural layers of the lungs, so open or otherwise. Pneumomediastinum again is just air around the layers of the mediastinum, and pneumoperitoneum around the lining of the abdominal organs. So anyone with chest or abdominal injuries is at risk of one or more of the above. So we can give Entonox just with caution. We just need to monitor them. So someone who you think might have a pneumothorax might not be appropriate to give them Entonox. But if you do decide to, then you need to keep an eye on making sure they don't become more breathless. And all these contraindications are to do with the expansion of nitrogen within the body, and Entonox encourages that. And it's thought to be one of the reasons why it does actually work as a pain reliever, but it's also one of the reasons why it can make some people worse. So just bear those in mind. You do need, if you are going to be administering these medications, I always say to people, you don't need to buy the gel cap pocketbook just to administer oxygen and Entonox. But you do need to have access to the contraindications and the side effect profile for anything you're administering, because you need to get informed consent from your patients before you administer a drug. Good. Just quickly flicking over some oxygen delivery equipment on the left of the screen at the top there, you've got the bag valve mask, of course, that gives anything with a bag attached. You'll see the bag valve mask and the non-rebreather mask both have bags that inflate. If they have a bag attached that inflates, it's capable of delivering roughly 100% oxygen. That also means that they have to have 15 litres per minute. So BNF, yeah, absolutely, BNF is free, but it's very wordy. Yes, absolutely, medicines is good for uni students as well, but or you can just find a friend with gel calc and screenshot it. So your anything to do with 100% oxygen has to be 15 litres per minute on the oxygen cylinder. So we use the bag valve mask. The only time we use that is when the patient's not breathing. The non-rebreather mask would be for any patient that is breathing that you want to give 100% oxygen to. So then you have the Venturi mask. The Venturi mask, they have variable flow, as in each set of masks will have different flow rates. It says on the packet how much oxygen to put through it, and it will tell you what percentage of inspired oxygen the patient will get. As I say, you may have the choice of more than one, you may only have one, you may only have 35% or 40%, for example. And you just choose between that and the 100% mask, depending on the level of oxygen that the patient has, their saturations. And then you have the nasal cannula down bottom right there. So this is the only one that has a variable flow as such that we can change. So this is the only one you need to use your brain as to how many litres a minute you put from the oxygen cylinder. You can put up to 6 litres. Anything over 6 litres becomes uncomfortable. As I say, every litre increases the inspired oxygen by 4%. Patient again has to be breathing, and again, you're going to be using this either for your COPD patients or for your patients that are sitting in that 85 to 93% category, same as your Venturi mask. Your non-rebreather mask will be red box guidance and patients less than 85%. And your bag valve mask for any patients not breathing. Entonox, that's the mouthpiece. You get a plastic disposable mouthpiece that slides over that for infection prevention control. Normally has a bacterial filter between it, and the metal end plugs into the Entonox cylinder. It's that metal end that can fly out under force, and they're relatively heavy, solid metal. They can fly out under force if you don't turn the cylinder off before you disconnect it from the Schroeder valve, and it's that knocks somebody's tooth out. It wasn't a pleasant experience for them. So, but that is that. Hopefully that's not all brand new to you. I said tonight was going to be relatively quick. There isn't a huge amount you need to know about oxygen and Entonox, but of course, if you're going through your FREC 4, this is going to be covered, and it's always good. It's part of your mandatory pre-reading for the FREC 4 course. And something that everybody should be familiar with. So, absolutely, yes, thanks Matt for the plug there. We do sell the gel calc pocketbooks if you do want to buy them, but if you are only administering oxygen and Entonox, I don't advise buying a gel calc just for that. If you're going on to do the SARM course, absolutely, it's almost a must have. Let's have the quiz then, shall we? So there are 23 of you still hanging around, so let's go into quiz mode. As many of you as possible want to join. So go to menti.com now, 76818049. If you want to join in our quiz for a chance to win 10% off, please do sign up now. Once I start the quiz, you can't join. There's 5 questions. The quickest answers get the most points, and the person that scores the most over the 5 questions will win 10% off any course of their choosing. Please do use if you haven't signed up already and you intend to, use your real name so we can tally it up at the end. So I've got 10 in. Does anyone else want to join? 11. Good, right. I shall make a start then. So looking at your phones, you'll get a question on the screen. Which of these is a contraindication for Entonox? A, B, C, or D? Don't get long to answer. Quickest answer wins. Good. 8 of you got that right. Diving in the last 24 hours puts you at risk of the bends. Flying doesn't count. Chest trauma is a caution. Minor head injury is only if it's significant enough to cause altered levels of consciousness, in which case it wouldn't be a minor head injury. So congratulations to the 8 of you that's got that right. Let's see who answered that in the fastest time. Rob. Well done, Rob. Excellent. So we have a leader at the start of question 1. So when everybody's ready, looking at your phones again, we'll start the countdown. Here is question 2 for you. Which of these patients will be administered 100% oxygen? Use 2 of 2. Open ankle fracture, COPD patient with sepsis, or a healthy adult with SATs of 93%. Oh, perfect. 4 of you got that right. So use 2 of 2 wouldn't necessarily mean anything. That could be a well patient. Open ankle fracture wouldn't class as major trauma. COPD patient with sepsis is a critical illness requiring 100% oxygen regardless of SATs, and that doesn't differentiate between COPD and non, so that is the correct answer. Healthy adult with SATs of 93% wouldn't be given 100% oxygen. They'd be given a nasal cannula or a Venturi mask, or just told to take a deep breath and get it to 94. In real life. So good. Let's see who got that correct and who got it correct the fastest. So Matt was the fastest there. Well done, Matt. So you're up there. Good. Up there in 3rd place. So Rob, Gary, and Matt in the lead. Well done. Very good. Go to question 2. 3 even. I can count. Look at your phones. Quickest answer wins. Which of these patients is it most appropriate to give Entonox to? Most appropriate to give Entonox to? Very good, very good. Okay, 5 of you getting that right. So good, everyone spotted the contraindication, head injury with confusion. Stabbing to the chest, yes, you could give it. It's a massive caution there, isn't there? Severe abdominal pain with absent bowel sounds is a contraindication that could suggest bowel obstruction. And 5 of you getting Braxton Hicks contractions would be considered labour pain. So that is the most appropriate of those two to give to. So I'll pay 5 of you, well done. For getting that right. Let's see who got that fastest. Okay, well done. So Rob's still in the lead. Well done, Rob, Gary, and Mark. Fantastic. So for question 4, looking at your phones. Which of the following cannot be used around medical gases? Oil grease, cleaner wipes, alcohol gel, or an ECG machine? Yeah, good, nice and easy. Everyone voted on that one. Okie dokie. 8 of you got that right. Lovely. Oil or grease cannot be used around. Clinell wipes can. They're safe around everything. Alcohol gel can. Absolutely fine. ECG machine. Absolutely fine. It's the defibrillator that you might want to be a little bit more careful with. But oil or grease is the correct answer. Hydrocarbons can spontaneously combust around 100% oxygen. Good. So let's see who got that right in the fastest time. So Rob holding on to the lead there. Rob, Gary, and Matt in first, second, third. Very well done, folks. Let's go into the last question then. Let's see. Could be all to play for. Remember, so last question, looking at your screens, answering as quick as you can. Here it comes. When is it no longer necessary to remove oxygen before defibrillation? When a paramedic tells you when an OP airway is inserted, when an IGL or tube is inserted, or when connected to a BVM, maybe C or D. Excellent, most of you getting that right. So 2 of you said when the paramedic tells you to. Paramedics aren't always right, so don't always do what your paramedic tells you to do, especially not if they say don't move the oxygen when you're not in a closed circuit. So OP airway wouldn't be a closed circuit, so we still have to remove oxygen then. IGLs and endotracheal tubes are considered closed circuits, i.e. the oxygen can't leak out all over the patient's chest. So defibrillation with oxygen attached is absolutely fine when connected to the BVM with the red herring in there. So well done to those 5 of you that got that. Who answered fastest, and have we changed the leaderboard? We have changed the leaderboard. Let's have a look. Have we? Not quite. Matt, how many times are you going to come second? Rob, very well done. You despite getting the last question wrong, we snuck in the lead there. So Rob with 3,422 points, which sounds amazing. And you have won 10% off a course of your choosing. So Rob, if you don't, yes, every week, Matt, you are second. So Rob, if you don't mind just getting your email address to us at some point, or if you have a course in mind that you want to do already, then let us know and we'll honour that for you. And just get in touch with us somehow. That would be great. Let's pop you back to the slides then. That's it for tonight. We are back, as I say, really excited about the return of some ECG stuff. Anyone that knows me knows that's my area of specialty. So we've got ECG Basics Part 1 starting next Wednesday at 7:30. I'd really like to see a capacity crowd for that. I think that's one that most people are interested in. So do spread the word. Charlotte's just put a link in the chat. If you'd be kind enough to leave us a review, that would be really, really nice of you. That really does help get people to us. Of course, there's a link there for your CPD certificate, which is what most of you are after. So you get a free CPD certificate for doing this. So do click on that. The link is in the chat now. Do have a look for it. Do click on it before we go. If you miss it, don't worry though. It will appear on our Facebook post and on our website as it does every week. So we'll be back, as I say, Wednesday the 3rd, which is next Wednesday at 7:30 again, ECG Part 1, and then ECG Part 2 the following week. It's aimed at people going through FREC 4, so this isn't going to be loads of detail. If you want to go into loads of detail, we'll be rerunning our ECG series in the new year. So that's that. I'll take questions from the audience. You're more than welcome, folks, for those of you that are leaving. Thanks very much for coming. As I say, the link, Charlotte's put the link in the chat for places you can leave reviews and for our CPD certificate. If you would like to claim that, grab that now, or you can come to our Facebook or website later and it'll be there. I should also say, those of you that are interested in FREC 5, there is now a register an interest link on our page. So go to our website under pre-hospital care. You've got FREC, there's a page for FREC 5 now. We're going to keep that up to date as we progress through approval stages. So if you are interested in doing your FREC 5, there is a section there just to fill in to register an interest. We hope that the first course will be running in April, but there's a lot that could go wrong between now and then. So don't hold me to that. You're more than welcome, everyone. Have a great evening, those of you leaving us, and we hope to see you next week. Any questions? Thanks, Matt. Any questions, folks? If not, I'm going to pause the recording there.